So malaria, malaria is a condition of course, which is caused by a parasite, right? The thing about this parasite is the parasite has different species, right? So how do you say that this patient or this person might be suffering from malaria? The crucial clue in history is fever, chills, rigors. So basically, you ask the patient high grade fever, and also you ask the patient is he having chills while he is having a fever? Is he having rigors? Is he shaking? Is he shaking and and that is a clue in terms of the history. On examination, you might find hepatomegaly, you might find hepatosplenomegaly. One of the DDs in a young patient coming with the complaint of hepatosplenomegaly is malaria, right? So you should keep that in mind when you see a patient with hepatosplenomegaly, right? So now you have a patient coming with a complaint of fever, chills, and rigors, right? Typical symptoms. So how do you go about and what are the investigations that will lead you towards a diagnosis? In our clinical setup, what we do is we go for MP, malarial parasite, right? Present or absent. You can, but the tests that are recommended are basically blood films, which are the thick and the thin films, and then you have the rapid antigen test, right? So what are the thick and thin films? Thick film is basically for the detection of the parasite, right? But it's not going to tell you what kind of parasite it is, what species of parasite is in your blood, right? So parasitemia can be detected by the thick, while thin is for specific antigen. Specific species, right? So what are basically the species? We have Plasmodium falciparum, which is very deadly in terms of its manifestations because it can lead to really serious manifestation with regard to the CNS system, with regard to causing renal failure. So it's a very serious condition, falciparum. Second is vivax, whale, and then fourth is malaria, right? So the thing about malaria is fals, Plasmodium malariae is that it's going to cause fever every fourth day. So you can also ask, in the history that, oh, when you have fever, does that occur every fourth day? Is it like Corton fever? It's called Corton fever, and if it occurs every third day. So if it occurs every third day, it might be Vivax or Ovale or Falciparum. So after 72 hours, if I'm not wrong, it's after 72 hours, the Corton fever. So you can, these can be important clues in your history, right? An exam is going to be hepatosplenomegaly, and you can rule out lymphoma by checking the lymph nodes, right? If they are palpable, then obviously you're going to go with lymphoma or leukemias or other malignant conditions. But typically, when you see hepatosplenomegaly patient coming with fever and chills and rigors, the most likely diagnosis in your mind should be malaria, right? Because it's in our tropical countries like Pakistan, close to the equator, malaria is particularly very common. You can also ask in history, okay, do you belong to an area, or in your region are other people being diagnosed with malaria? The prevalence rates of certain areas are higher as compared to other areas. So you can also ask about that in your history. That can give you a clue as to the diagnosis, right? You can also ask about dengue, right? But typically, when it comes to dengue, you will not be having hepatosplenomegaly, and also you will have the rash. You can ask about the rash. You have like this reddish rash and some kind of maculopapular rash, and typically it's not a maculopapular rash, it's a petechiae, because of the bleeding, because of the decrease in platelet count that's causing the purpura, right? So but obviously when it comes to patient, you're not going to ask, do you have petechiae? You will ask rash, right? So it's not a maculopapular, it's a petechiae, right? You will see that. You'd observe that, and patient will also observe that. So coming back to the investigations, we talked about thick and thin films. It's okay. It's like it's a given that that's how you diagnose it. And then now we have the diagnosis in our hands, right? We also know the species of the of the plasmodium, right? Now how you go about treating it, that's the complicated part, because they're like, all, be it falciparum or be it your Vivax and Avail, both, all of them are treated in 3 days. Remember, 3 days is the cutoff point. You treated these plasmodium species in 3 days, but the way the tablet structure is like, the tablets and the dosages are basically a little complicated. So bear with me. The tablet that you go for in treating the vaccine ovale is chloroquine. So chloroquine is given 4 tablets. 10 stat 4 tablets. Stat means you will just ask the patient to eat 4 tablets, take 4 tablets, that at that particular day. 4 tablets, each tablet has 150 mg, so 4 tablets stat at that very moment, right? And then you'll ask the patient that after 6 hours, or if it's morning, you'll ask the patient to take 2 tablets after, like, at evening, right? But if the patient is taking the 4 tablets at noon, ask the patient to take the other 2 tablets at night. So 6 hour gap, right? So the total of 6 tablets would be given to the patient the first day, right? And the second day, you'll ask the patient to take 1 tablet at morning, and then the other tablet at evening, right? So that's how it's structured: 150 mg BD, and then the third day 150 mg BD, right? So 2 tablets in total. So that's the treatment of Vivax and Avail. And then comes the other part. After 3 days, you'll go for Primaquine. Primaquine 15 mg per 15 mg every day for OD for 14 days. Primaquine OD for 14 days. But before that, if it's a male, then you have to go for G6PD, because that could lead to, if you have the G6PD deficiency, then in males it could really aggravate the hemolysis. Um, that's that will be deadly, right? So why do you go for Primaquine? Because Vivax and Avail has an exoerythrocytic phase, and an exoerythrocytic phase is basically the phase where malaria, like the parasite malaria, Plasmodium malaria, normally go for the RBCs, but this Vivax and Avail Plasmodiums, this particular species, go for having hypnozoids in liver. So what happens is, you will see in Vivax and Avail, you'll have like a relapse of malaria because of the hypnozoids that will be present in the liver. So in order to eradicate those hypnozoids, you need to have Primaquine, which you will give OD 15 mg for 14 days, and that's it for Vivax and Avail. Now moving forward to falciparum. Now when it comes to falciparum, you will change the drug. It's not going to be chloroquine. It's going to be co-artemether. And co-artemether is artemether with lumefantrine. In Pakistan, you have Genem, right? The trade name is Genem, while the generic name is artemether with lumefantrine, right? So how do you go about giving the dose, right? So first, it's going to be the same 4 tablets stat. But then after 6 hours, you're going to go for 4 tablets. So you'll ask the patient, take these 4 tablets. Then after 6 hours, or if you're taking it morning, take it at evening, and so on and so forth, 4 tablets. Then the next day, take 4 tablets in the morning and 4 tablets at night, and the third day takes 4 tablets in the morning and 4 tablets at night. Like, so this is basically, you need to have 24 tablets. So basically the dosage of this artemether is 24 tablets for 24 tablets, um, for a total of 3 days. So 3 days when you have to take 24 tablets. So this is a like this gets a little like tricky, but once you get a hang of it, you realize what it is. Like, now coming to cases where you have a complicated falciparum malaria, which is basically when you have a CNS infection. For example, you have a black water fever, which is basically renal failure when you have excessive hemolysis, because malaria, what does it do? It targets RBCs, and it causes the hemolysis, or it causes the breakdown of RBCs, and excessive breakdown of RBCs will release hemoglobin. Hemoglobin is in RBCs. Hemoglobin will cause the clogging of basically these vessels that could lead to a CNS infection, or also it could also lead to renal failure because of the excessive amounts of hemoglobin that is in the blood. The kidneys will filter that blood, right? So excessive hemoglobin will cause the kidneys to go into renal failure because of the excessive load of filtration, because of the excessive hemolysis that's taking place, because of the excessive hemoglobin that will cause the renal failure to happen. And that will also lead to hemoglobinuria, because now the kidney's filtration ability is being compromised because of the excessive amounts of hemoglobin that is in the blood that cannot be filtered. So basically that leads to an inability to filter the blood because of the excessive hemoglobin so it will appear in your urine. So the patient will also have fever, will also have chills, rigors, and also have hemoglobinuria, right? Will also complain of red urine. So red urine might not necessarily mean RBCs. It could also mean hemoglobinuria. It could also mean myoglobinuria. So that's something that you can look into. And in those conditions where you have a severe falciparum sort of infection, then you go for 2.4 mg per kg IV stat IV at 0 hours, 12 hours, 24 hours, then every day for 7 days. And even then, if it persists, then you go for other tests, like for example, if the coma, convulsions, and even the patient is not, the GCS is not improving, then you go for LP, right, lumbar puncture, so you can so as to rule out other causes of infection, CNS infection like meningitis, encephalitis, and others, right? So yeah, that's malaria. And malaria is pretty complicated because of the treatment, because it's like 4 tablets, 2 tablets, 3 tablets, 4 tablets. What the hell is that even mean? So yeah.